Good morning, everyone. This is a very special Grand Rounds. Not only is it the last one of the year, I finally convinced Werner.
My slide.
I'm sure it'll be okay if you see it, if they see it twice. Just to show you that nobody is above the faculty rule of giving Grand Rounds every 3 years, Werner is going to be presenting this morning. Werner is a UW product, tried and true. He did his undergraduate, his medical school, his internship, his residency, his fellowship, and then came on faculty here. This is, when I first got here, I gave a talk to some of the alumni, and this was the earliest photograph I could find of the division, which I then went to Werner and we tried to date, and we think it's probably around 1959. And if true, Werner was just sort of a second-year cardiology fellow at that time. And you can see here the rest of the division. And he tells me they had to comb Harborview to find enough people to stand in on the photograph that it looked like a real division, as opposed to a couple guys who got together for a quick selfie. Since he has been out, he's held a number of positions, both in the university and the state. He was the governor of the Washington State ACC. He was the president of the Washington State AHA. He's been president of the King County Medical Society. And then probably his least thankful job was he became assistant dean a couple of decades ago and oversaw medical student admissions for a number of years, and then became an associate dean. And then I think that was his first retirement, and then he came back to work, and then we have conscripted him down in clinic, and he continues to see patients a couple days of a week. Werner is one of the, as you can see, the original three. It's very rare to be able to have someone who can look back over the last 50 years or so and has been involved right from the very beginning. And I'd like to thank Werner for giving us this overview and look forward to it. So it's all yours, Werner.
Where do we go? This one, okay. This is the most important slide. Thanks, Rob, for the nice introduction, but this is the most important slide here. Anybody who expects a scientific dissertation will be mightily disappointed. Briefly, I'm going to outline the start of this medical school in the Division of Cardiology and snippets of occurrences and management of cardiac issues, mainly over the 4 decades since 1950. Anything that happened over the almost 20 years that I migrated from Pill Hill here is known to most of you, and I can't cover everything in my allotted time. Oops, where are we? Oh, there we are. This one. Okay. Now, the medical school, actually there was a discussion about starting a medical school ever since the 1860s, but often the medical profession here was opposed to it. Finally, at the end of World War II, when people realized that there is a shortage of physicians, and most of the pre-med students here went either to the University of Oregon Medical School or to Northwestern, the decision was to go ahead and start a medical school. And Governor Walgren signed the legislation for it. here in the end is the Senate Majority Leader, Al Rossolini, who some of you may have seen, who kind of got some of his care here until he died at the ripe old age of 101. Groundbreaking ceremonies were in March 1947. No, that's not the one. Wait a minute here. This, you took my computer away. I rather had my computer. Here we are. There we are.
That's back.
Okay. Anyhow, this was the area where the medical school is now. This was a golf course. A lot of people were very upset that the medical school was taking over a golf course. You know which? I can't see. Now, I'm somewhat of a pack rat, and I found this newspaper, which is a little yellowish, but that shows that was a headline in the Seattle Post-Intelligencer in October when the University Health Science Building was dedicated. And this is the president of the, Jesus Christ. Well, anyhow, that's Ray Allen. He's the president of the university. And this is the medical school, also in the paper at that time, and that was the original building. Now, this was in 1949, not the first class actually started in 1946. And what are you doing to me now? Okay, that's much better.
And then forwards and backwards.
No, don't advance it yet.
Yeah. Let you go forward.
That's good.
Laser, and then forward.
What? Oh, amazing. In 1949, the 1946, the first class started. You do. And there's Dean Turner, the third one from the right, who was the first dean of the medical school. He actually was dean at American University in Beirut and at Harry University, and he came here in 1946. This was the first. The university, the medical school, did not have any building when it started originally. This was a shack outside King County Hospital, now known as Harborview, and that's where the administrative staff resided. Bob Bruce came in 1950 from the University of Rochester, was appointed division chief at that time, and as everybody knows, his major interests were treadmill stress testing, which was used as a diagnostic tool to replace the old master's two-step test. And he continued his research here. Later years, actually, Seattle was involved, physicians in Seattle were involved in what's called the Seattle Heart Watch program to assess the predictive value of stress testing. And Bob Bruce, as you know, is really the father of exercise testing. I was a student fellow with Bob Bruce, the first student fellow had. at the time when I was a student, which was, well, I hate to tell you when it was, but it was in 1900, and when I worked with Bob Bruce was in 1951. At that time, there were a lot of people here having rheumatic fever, and I did evaluate the relative effectiveness of aspirin, ACTH, and cortisone in the treatment of rheumatic fever of all the patients admitted to King County Hospital. You probably can't see that, but that's my summary. Basically, ACTH works best, but as you know, rheumatic fever is like an iceberg. Most of it is underwater. Only part of it is over water, and we suppress the symptoms, but we really don't do very much in the treatment as far as the process of the disease is concerned. In 1953 to 55, I was an intern and resident at the University of Rochester, where Bob Bruce came from, and I must admit that I had a little help. At that time, the chief of medicine at the University of Rochester, the Department of Medicine, didn't believe in the match. So I had to commit myself beforehand, and I knew right away where I was going. We can't do that anymore. In 1955, I protected this country in the U.S. Air Force. Stationed outside Oxford, I had the opportunity to attend medical rounds at the Radcliffe Infirmary. And the best thing about attending rounds at the Radcliffe Infirmary is that after rounds you go to the pub. I came back in 1957, 58 for the medical residency here, and then cardiology fellowship in 1958 till 1960. Whoops, I'm going in the wrong direction. This is a residence in 1957. What happens here? Oh, God. I wish I got that. Anyhow, in the middle is Bob Williams, who was the first chief of medicine, and who really in many ways was the father of this medical school. Dean Turner got a very good group of people together, but it was Bob Williams who really recruited the staff and appointed important people in the Division of Medicine, in the Department of Medicine. Next to him on the left is Bud Evans, and many of you may have heard of Bud Evans. There's an Evans Award given to a resident, to the medical student each year. He was an outstanding clinician and very humanitarian individual. He actually was chief at the VA hospital, and it decided that he wanted to learn more about electrocardiography. So in the early 60s, he came to Harborview every morning at 9 o'clock to read EKGs with me. And one day he didn't show up. And what happened is we had a reversible lane from the east side, and he came on one of the lanes, and somebody else went into the reversible lane, hit him, and he was decapitated at that time. So that was rather sad. Now, you know, I like this pointer better if it works. The fellow there at the top to the right is Hal Sandler. Hal Sandler is the one who worked. Well, you don't know how to work it either. What?
This way. That button.
There's a button there? Yeah. Okay. Alexander. The reason I'm pointing him out, he worked with Hal Dodge for many years, especially in evaluating left ventricular volumes, and he really did the majority of the work. This fellow here is Art Anderson, who became one of our partners in the Seattle Heart Clinic. Now, one thing, when I was a cardiology fellow, actually, when I was in the service, I attended the European Congress of Cardiology in Stockholm and met Alan Scher, who was in the physiology department here and was very much interested in ventricular depolarization and the genesis of the QRS complex. And I, later on, when I came back to Seattle in my 6 months of research, I investigated ST segment changes in acute myocardial infarction. And there's a paper which is still being quoted. I wouldn't be able to tell you all about it right now, but anyhow, we used a lot of dogs doing unipolar action potential of the dogs. We wouldn't be able to do that nowadays. Also, with Al Scher, we worked on a program textbook of electrocardiology, self-tuition, but we stopped that. We never quite got to it. At the end of my fellowship working with Al Scher, I was actually asked by Dick Dürer, who was an eminent electrophysiologist in Amsterdam, to spend a year with him. And after much discussion, I decided not to do that and go into private practice rather than going into academic medicine. I wasn't inclined to ask for research funds all the time. Besides, I don't think I would have made a good researcher in the first place. This is Al Scher on the left there, and that's his wife, who actually was a medical student 1 year behind me. And that's next to is Bob Petersdorf, who came here as chief of medicine at King County Hospital. Later on became chief of medicine here, then went to the Brigham as CEO at the hospital, then went to the University of San Diego as dean, and eventually became president of the UWMC, American Association of Medical Colleges. I'll talk about the 1950s. Several things happened. One of the important things was external defibrillation. AC was Paul Zoll, and DC was Bernie Lown. Bernie Lown was an interesting character. You know about Lown-Ganong-Levine syndrome, and he did many other things. But during the Korean War, physicians were required to go to the service, and Bernie refused to sign the loyalty oaths. So rather than going in as a physician, he came to Madigan Army Hospital to sweep the hospital floors. And he was there for a couple of years until well-known local attorney took his case and he got him out of it, and he finally became a physician. Bernie Lown eventually won the Nobel Prize, but it wasn't for cardiology. It was because he was the founder of Physicians for Social Responsibility. I was involved in the first DC cardioversion at King County Hospital. I hate to admit it, but the first one we did without anesthesia We thought the shock was only a split second and nobody would notice it, but we were surprised, so we changed things after that. I well remember one of my first DC cardioversion at Swedish Hospital, and the patient was cardioverted, did very well. And 4 weeks later, he came to my office, madder than hell. And I asked him, what's the problem? He said, you know what? The anesthesiologist who was there charged me 4 times as much as you did for cardioversion. So we decided at that time that we were going to give the diazepam intravenously by ourselves. And we did the cardioversion without help of an anesthesiologist for many years. Right, Freud? Also in the 1950s, actually, when I was in my last year of cardiology fellowship, Bob Bruce proposed streptokinase injection above the aortic valve, and we gave streptokinase to terminal cancer patients to see what the reactions were. There was no IRB at that time. We couldn't do it anymore. And then actually asked for NIH for grants to investigate this further, but the NIH said this was too daring a procedure and refused to fund further investigation. In the 50s, the major operation really surgically was a closed commissurotomy, whereby the surgeon put his finger through the atrial appendage and opened the valve with either with his finger or with a knife at the end of the finger, and then tied up the atrial appendage. And we also did closed aortic valvulotomies, introducing the valvular tube through the apex, and this caused a peri-infarction block and gave me an opportunity to write a paper on development of left parietal block, now known as left anterior fascicular block. Now, just to talk a little bit about treatment of myocardial infarction in the 1950s, the most important thing was bed rest, and people were put on bed rest for 4 to 6 weeks. There was finally Sam Levine, who was a prominent physician in Boston, decided that you might get the patient out of bed a little earlier and suggested that they get out of bed and sit in a chair on the 2nd or 3rd day. Many people thought that was crazy, but it worked out all right. The thing that impressed me about Sam Levine is that he was a lovely gentleman. He actually came here, gave a talk. But I saw a patient early in practice who was seen by Sam Levine and was impressed by his letterhead. The letterhead had Sam Levine, Boston, Massachusetts. No degrees, nothing else. Now I find here some of our colleagues have so many titles and have so many things they write about that the letterhead usually occupies half of the first page. So that what impressed me about Sam Levine. Now we gave oxygen, morphine, and early heparin, and the big controversy at that time was whether there should be long-term warfarin therapy. Back and forth, very controversial. Finally decided that probably didn't make too much good to continue it. Therapy of angina, we had amyl nitrate, nitroglycerin, and long-acting nitrates, Paratrate. I remember Bob Bruce coming from the AHA meeting, all enthused about that new drug, Paratrate. And the other interesting thing is some people recommending making the patient hypothyroid, not realizing that if you're hypothyroid, your cholesterol level goes up and things actually get worse instead of better. As far as hypertension is concerned, well, we had limited number of drugs. Most important one was reserpine. There was pentylinium, a gangliotic blocking agent, and the Kempner-Duke rice diet, where people were put on a rice diet for weeks on end. Some of them were hospitalized for a while, and that usually lowered the blood pressure. Smithwick operation, lumbosacral sympathectomy, was in vogue, and one of my office companions, who was a cardiologist who trained under Paul Dudley White, who was a well-known cardiologist, had a lumbosacral sympathectomy. The problem was that he was then constantly hypotensive and had constant pain, and it was so bad that he eventually committed suicide. Thiazide diuretics first came out in 1957. Alpha-bulk or methyl dopa was used, and apresoline, which reduces catecholamines, was one of the drugs used in the 1950s. Heart failure therapy was interesting. All patients were digitalized with warbane, which doesn't exist anymore, IV aminophylline, rotating tourniquets, phlebotomy, and mercurial diuretics, either given IM or subcutaneously. Chronic heart failure, also with mercurial diuretic, mercuride and cyromarin, and we gave the cyromarin like insulin. In other words, the patient injected about, I think, a cc subcutaneously himself for diuresis. The problem was that the mercurial diuretics were very nephrotoxic. Now, the other interesting thing is Southey tubes. I don't know how many know about the Southey tubes, but that's the capillary that was introduced into Demeter's legs, and the fluid, and the patient put his feet in the bucket, and the fluid ran out into the bucket. And I can remember very well at Harborview Hospital, people sitting in the hallway, all sitting there with their feet in the bucket, and the fluid was running out. In 1957, we had thiazide diuretic, then we got spironolactone, a loop diuretic, and all the other drugs that we're using now. In 1978, there was the first paper from Sweden about the effect of chronic beta-adrenergic receptor blockade in congestive heart failure, which eventually led to the use of beta-adrenergic drugs in the treatment of heart failure. This is a picture that Dr. McClellan showed, and you see Len Karp, that other fellow next to Dr. Bruce. The one fellow on the top right is John Morledge, who was a cardiology fellow and then went into practice in Madison, Wisconsin. He may be there with Rick Page nowadays. In 1960, I started private practice. I was a third invasive cardiologist in Seattle. We had two other invasive cardiologists, both of them graduates of the University of Washington Division of Cardiology. The diagnostic studies at Swedish Hospital, one of the cardiologists, who was kind of an entertaining fellow, asked me to assist him when he did the catheterizations. And the most interesting thing I found is initially, very early, that in order to get a left atrial pressure, he stuck the needle from the back into the left atrium, got a straight line and called it left atrial pressure. and I didn't quite agree with that. The other interesting thing about this fellow is, which I wish sometimes I would do here, if people, he read electrocardiograms, and if a patient had an electrocardiogram 2-3 days in a row, he would write on the diagnosis, "Are you treating this patient with electrocardiograms?" Now, I feel this way here, to be very honest. I haven't dared yet put that in the diagnosis, but I have put in the diagnosis. There has been no significant change over the last 180 minutes. So, now, private practice was a little different there. First of all, as a cardiologist, initially you really didn't do very much. You did a few diagnostic studies, and you put the patient to bed and gave them some of the drugs that I outlined. When I started, I shuttled between 8 hospitals. Nowadays, we do that anymore. When you got into practice, you had to network in order to get referrals and get patients. Nowadays, our graduates go out, they join a group, and they never have to network. They got more patients than they want to get. I went to Providence, which is now Swedish, Virginia Mason, Cabrini, the Catholic Hospital, which doesn't exist anymore, Seattle General, which doesn't exist anymore, Maynard, which doesn't exist anymore, Ballard Hospital, which is now Ballard Swedish, and I actually had an office in Ballard for a while, and Waldo General, which was an osteopathic hospital. We even went there to see patients. I also, in 1960, became chief of cardiology at King Cardi, making inpatient rounds and supervised once weekly cardiology clinics staffed by town cardiologists, in quotation, because most of the people there at that time were really not boarded in cardiology. We had one individual, and Karen will be interested in that, who knew for sure why we had patients with congenital heart disease. And he knew it's because of rough sex during the first trimester. And he actually told that to the medical students and residents. Now, I think only in Seattle at that time, there were only about 3 specially boarded individuals. Now, I don't know whether you know, but the cardiovascular boards in the 1940s existed of taking 10 EKGs after you finished your oral examination for internal medicine. And if you could interpret those 10 EKGs, you were boarded in cardiology. That changed in the 1950s when we had oral examinations, and I remember we had a total of 10 examiners. Willis Hurst was one of my examiners. And I think I told some people, Gene Brownwald took the boats at the same time I took it. And we came to the radiologist who showed us X-ray, and he put up an X-ray. And I can't hammer it hard. It was a corrected transposition. And a radiologist said, well, Dr. Brownwald got the answer. And I couldn't help myself. I said, now, who's examining whom? Dr. Brownwald, the examiner, or the examiner, Dr. Brownwald? And the radiologist said, don't kid yourself. He missed 2 normal chest X-rays. So, there was an EKG guy, lovely old fellow, came from Europe, and I remember the most important question was, what is Ashman phenomena? And I'm sure everybody knows about the Ashman phenomenon. Now, first coronary care unit was in Kansas City in 1962, but actually wasn't in general use until about 1965. I remember our first monitor at Swedish Hospital. We had one monitor on the floor, and you had to turn it on. And I had one patient who had third-degree AV block, and he turned around whenever he was close to fainting. He turned the machine on, and we could see that he had a complete heart block. So that was our first monitor. At that time, we gave IV lidocaine for every myocardial infarction patient, which was recommended by Bernie Lawn. Early detection of left ventricular failure, Swan-Ganz catheter came into vogue. I know whenever anybody had RALs, we started them on digoxin, now knowing that that was the wrong thing to do because it does increase myocardial oxygen consumption. Nitroglycerin at that time was contraindicated because people felt people would be too hypotensive. We saw a lot, we saw cardiogenic shock, ventricular septal defects, papillary muscle rupture, not infrequently. And things have really changed because those complications of myocardial infarction, or what we now call STEMI, is really seen rarely. At that time, we trained the nurses to read rhythm strips and use a defibrillator. In the 1960s, there was surgical management of coronary artery disease. One was poudrage, whereby you put talcum powder in the pericardial sac and hope collateral vessels form. Internal mammary artery implantation, the Weinberg procedure, where you just stick the internal mammary artery into the myocardium, which doesn't work. And internal mammary ligation, the idea being if you ligate the internal mammary artery, the pressure proximal to the ligation would increase, and you would get collateral vessels to the myocardium. Len Korb and Bruce, actually, Len Korb did most of the studies, debunked the theory by we have 17 patients who were operated on, and what happened is they took the internal, they put the ligature around the internal mammary artery, two arteries, and then somebody gave the surgeon the envelope, which this nurse opened, and told him whether to ligate or not ligate. And after this, we would do stress testing to see how the patient did. And I remember very well doing stress tests on these patients, and the one who had the best performance had the sham operation. Then we had patch reconstruction of coronary arteries, and in May 1967, Favellaro performed the first coronary artery bypass graft at the Cleveland Clinic. Coronary arteriography initially were intercalated supravalvular aortic injection. In other words, the injection was made during diastole. We actually sometimes gave acetylcholine to stop the heart, which caused chest pain in the operator. Sohn's technique was brachial artery cut down, and eventually Chutkan's technique with the percutaneous femoral artery approach, which has been the mainstay of coronary arteriography until now we go back to the radial artery. Bob Williams, who I said was the chief of medicine, had an inferior myocardial infarction here, and he had third-degree heart block. And that was an interesting story because 6 cardiologists attended him, and then several residents, and he would go into complete heart block, and some of the residents would jump on him and get the heart started again, and he would say, every time I wake up, somebody was jumping on my chest. And finally, Dr. Bruce obtained the first transvenous catheter, and it was actually written up in the American Heart Journal. Before we had pacemakers, we lowered the potassium in people to increase AV conduction because there was evidence that AV conduction was improved in people with Cushing's disease. So we gave diuretics to patients and get the potassium down to about 2.8, which nowadays would make everybody nervous. It actually worked at times, but not very often. Initial pacemakers were inserted to the jugular vein, and the pacemaker pack was outside the body. Also, we had a time where we had nuclear-powered pacemakers. It was a big occasion. I remember it made the front page of the Seattle Times, but the nuclear pacemaker didn't last very long. Now, valve surgery, and we got a surgeon here, so I don't know too much about it, but I can tell you that first valve was a Starr-Edwards valve, and we had the Burke-Charlie-Tilking disc valve. We had an aortic homograph promulgated by Barrett Boyce in New Zealand. The Ross procedure, transposing the pulmonic valve to the aortic valve, autogenous pericardial valve, and eventually the porcine valve. Now, we were aware of risk factors. This is from the Heart Association, and I think I indicated what you should do to minimize your chances of getting coronary artery disease. So I got my face in the paper quite frequently. I don't know how that happened, but I told people to go and walk and exercise, which was worthwhile. And I also wrote a letter, actually, the paper. Ackley was a big advertising guy in Seattle, and he was advertising cigarettes. And we weren't very happy about that, so at that time I was on the board of trustee of the King County Medical Society and wrote a letter to him to try to get rid of the cigarette advertising. Now we get to Medic One, which is one of the big accomplishments, I think, in Seattle. The first mobile coronary care unit was by Partridge in 1967 in Belfast, Ireland. And Len Cobb and Gordon Vickery was the Seattle fire chief, conceived Medic One. And I remember training the first bunch of paramedics in 1969. There were Len Cobb, another partner of mine, John Mazzarella, and myself, trained the first group, and the Medic One really got into action in the spring of 1970. Initially, it was funded by the Washington, Alaska Regional Medical Program, which was a program started by Lyndon Johnson. It was a healthcare initiative. It was run by Michael DeBakey in Houston. And there was funding from that outfit. Unfortunately, the funding ran out. And Here, I don't know where you can see it, but this shows you that we were only about $150,000 in the red. So there was a successful public appeal in the newspapers, and the response really was overwhelming as far as getting money is concerned. And at that time, the Medic One Foundation was established, which still is very active, getting money and except having enough money often to fund research projects. Floyd Short was president of the outfit 2 years ago, 3 years ago. Then we had Medic 2, where we trained the lay public to do CPR. In the middle is Gordon Vickery, who's a fire chief. Actually was really promulgated by the Rotary. This is Joe James, who owned the old Curiosity shop in Seattle. And actually last week, he was in the newspaper. He doesn't look as young anymore, but the old Curiosity shop on the waterfront still exists. I was at that time president of the Heart Association, and I looked a little younger then. And CPI instruction, again, you can see Len Cobb and Gordon Vickery working with Resuscian. Now, not everybody was happy with Medic One, and some people thought we shouldn't spend any money doing this. I don't know whether you can read this, probably not, but it was kind of an interesting note that Len Cobb sent to the paper, castigating the individual who was opposed to funding the Medic One outfit. We had lots of complaints. Again, you can see the yellow paper because, as I said, I'm a pack rat. This is people complaining that cardiologists don't give care to the general public. And the last note, I think the bottom note is from me, indicating that we do. Now, in 1970, we formed the Seattle Heart Clinic. Initially, 4 of us. Floyd Short is here. And all 1970, Hal Dodge, who actually was chief of cardiology at the VA, then went to Alabama as chief of cardiology, but he really was a Pacific Northwest guy, and he wanted to come back. And one day, I remember Sunday, I was making around at Ballard Hospital, and there was Hal Dodge on the line, and he wanted to start a cardiovascular research training center, actually at Swedish, in conjunction with the university. I think it was Bob Bruce who kind of put the kibosh on that. 1973, I was appointed as Dean of Admissions, that Dr. McClellan indicated. That had its negative effects in that some of the physicians in town were very disappointed when their offspring wasn't accepted, and it was always my fault. And I felt, in fact, I told the dean one day, I said, I've got to sell pencils on 4th and Pike to substitute my income because I'm losing patients. Specifically, I can think of a classmate of mine who son was applying. He was rejected the first time, and prior to his interview the second time, he called me at home and said, you know, my son has to be admitted to medical school because he's going to take over my practice. Well, I said, you know, we're not really considering you, we're considering your son. We didn't accept him. He was finally accepted in Eastern Virginia, I think, and unfortunately, rather than going to practice in general general practice with his father. He became a pediatrician, but then after a while committed suicide. But the interesting thing about this fellow is that after he was rejected the second time, but the physician who sent a fair number of patients to us, consultation, approached Dr. Short there and said, now, I'm not going to send any more patients to Werner, but if I send you any patients, will Werner get any of the money? So that is Hal Dodge in his younger days. This is Cardiology Fellowship. Bob Bruce, known to people. I think Jack Murray is mentioned there. I thought I put it in there so Jack doesn't feel neglected. And at that time, the fellows rotated through both Swedish and Providence Hospital. You can see Jim Caldwell being over at Swedish Hospital. Now, the first coronary artery bypass graft, the first patient I had, I frankly didn't trust any of the surgeons in Seattle. So I referred him to Al Starr in Portland. He had bypass surgery in 1970. This fellow, since that time, has had 2 more bypass surgery. He went into atrial flutter and had an ablation procedure here. Finally went into heart failure. We kept him out of heart failure. And he lived until 2 years ago when he had a sudden cardiac death, was resuscitated, but was mentally not with it. So this guy lived for over 40 years after his first bypass. Hal Dodge became director of the Division of Cardiology in co-director. Bob Bruce retired in 1987. First angioplasty was by Andreas Grunzig. It's not Grunzig, it's Grunzig. U with an umlaut, but there is no umlaut in the American keyboard. And Floyd and I attended the second coronary angioplasty demonstration at Emory with Grunzig there. I remember one case presented was a young man who, I think he had about 60% obstruction on the right coronary artery. He did have some vague pains. Didn't sound anginal, but he had vague pains. So Annivar Grunzig did the angioplasty, and when he inflated the balloon, the guy screamed out in pain. And he said, I've never had a pain like that in my life. And it turned out he had gallbladder disease. Which reminds me, at Ballard, I read EKGs in the morning, and one morning I came in and read EKGs, and somebody had a clear-cut inferior myocardial infarction, so I called the ward to notify the nurses, and I said, how is Mr. So-and-so doing? Oh, Mr. So-and-so is in surgery having his gallbladder out. Now, the first coronary stents were put in 1986. I must say I did angioplasties, but when it came to putting in stents, I kind of gave up. In fact, Mark Reisman, who is here, I don't know whether he's here, today did many of my patients that required stenting. Now, here's a good story. This is Harry King, who was a surgeon at Swedish. He trained with Al Starr, and he came to Seattle. And he actually was a pretty good surgeon, but he had personality quirks. And Don Miller actually joined Harry King in practice, but Harry fired Don. So Don had to go how many miles away from Swedish, I don't know, but he ended up at the university, and he had to stay away for several years, and after several years, he came back to Swedish, and that got Harry all upset. And one day, Harry invited my wife and me for dinner in Bellevue, and the main conversation was that he wanted me to commit to send all of his patients to him for surgery, whereupon I said no, whereupon he and his wife walked out and left me with a bill. And later on, he had problems, and and he then actually sued our group, myself, and Swedish Hospital, and John Miller for interference in his practice. And fortunately, the judge dismissed the suit against our clinic and against myself. And Swedish Hospital wanted to settle, but I said, this is absolutely ridiculous, don't do it. So we went to trial, and amongst others, I testified and told the story about my experience in the restaurant. And I looked at the jurors, and they were all smiling like that. And it took the jury 20 minutes to exonerate Swedish Hospital. Now, the judge who was in attendance, every time I see him, he asks me whatever happened to Harry. I don't know what happened. Oh, I know what happened to Harry. Harry went to Bismarck, North Dakota, got into trouble there and was fired, and then went to Houston to work with Cooley, but I don't know what happened after that. Now, I think myocardial infarction therapy in the 70s were glucose, insulin, and potassium, hyaluronidase, sodium in Mexico, hyaluronidase by Brownwald, steroid, which was quickly abandoned, propranolol, the wonder drug, that was the first beta blocker. Subsequent, we had cardioselective beta blockers, and I was invited actually to go to Monte Carlo to find out about a new beta blocker called tenormin. Anybody know what tenormin is? It's a tenolol. Anyhow, I felt a little sheepish, I must say, flew us from here to Idlewild. Idlewild is now JFK. And when I arrived there, there was a dean, and there was Bob Bruce, and there was Hal Dodge going on the same plane to Monte Carlo, so I didn't feel so badly about it. But the Bruces and my wife and I had a great time driving around the Corniche on the Riviera. Now, coronary streptokinase was first by Rentrop, and acute coronary bypass surgery was actually instituted in Spokane. And Spokane was extremely aggressive. And it says here, never put your hand over your heart in Spokane unless the national anthem is playing. Otherwise, a local doctor is going to diagnose coronary disease, and you wake up in the morning with a slightly modified heart. And that there was one of the surgeons there who would send all of his acute myocardial infarction to surgery. Well, the good thing is, first of all, they found out that people can have a coronary arteriogram when they have myocardial infarction, and secondly, that most of them survived after bypass surgery. Well, I'm going quickly on this. Most of this is obvious. hypertension, angina. We finally had calcium channel blockers, external counterpulsation for angina. In I think it was the late 1970s, one group came and wanted to start actually a research project here for the artificial heart, but some of us were not overly impressed. One of them was Bob Van Sitters, who became dean, who was very active actually later on, and commissions and committees for artificial hearts. And Barney Clark actually was a patient of our group. I met Barney Clark. Barney Clark was the first one to go to Utah to have a mechanical heart implanted. It was I don't think he didn't live very long, and there was a lot of controversy about cholesterol in the 80s. Some people thought that it was not doing any good, it wasn't necessary. We had a maverick in the Division of Cardiology, Tom Preston, who wrote a book first about physicians that they're no longer on a pedestal, and then he went on a rampage against bypass surgery, saying that 50% of the procedures are unnecessary. He wasn't entirely wrong, actually, and but he was an excellent physician and actually won awards for teaching here at the university. Echocardiography, I'm not going to say much other than I remember the first time I saw Feigenbaum, Harvey Feigenbaum present a mode echocardiogram at the Heart Association meeting, and I thought, this isn't going to go very far. You can see I finally attended a course in San Diego, well, anyhow, given by Tony DeMario, who's going to be a lecturer here in October. This is Ward Kennedy, who was active in the intercoronary myocardial infarction study. Myocardial infarction, intercoronary structure kinase, which was a community study. We participated in a private hospital, and he also studied whether antibiotic administration would decrease coronary event incidence. There was no convincing evidence. Just mention briefly Russ Ross, who was a pioneer in basic atherosclerosis research, who was on the faculty here and was an amazing fellow, very good friend of ours. I was involved in CME. The leader was George Agard, a dean, and there were 4 of us who gave talks. And I hate to say it, but all the people who were on the CMA course are dead, except for me. Which wasn't all work. That is Ed Bierman, who was chief of endocrinology, who was always on the tour. George Agard and his wife, and that young lady on the right happens to be my wife. 1980s, I attended the Bethesda Conference on Cardiology Manpower. I must say, thanks to Hal Dodge, I was involved in many meetings and committees. The big question was, who is this cardiologist? Should not be self-designation, but board certified. And we were training too many cardiologists at that time. In 1998, I moved to the university full-time, and I don't think much more to say about that. This is Hal Dodge, who died in 1999. This is a obituary in the New York Times about Bob Bruce, who died in 2004. My thanks to Memorial Bob Bruce, Hal Dodge, Al Sher, and Ward Kennedy. Ward was a good friend. In fact, we wanted Ward to join our group, but he decided not to. But he actually encouraged me to come here, but it was under Jim Ritchie that I came here. And then Rick Page and Jim Caldwell, who were very supportive, and most of all, Rob, who has been extremely supportive and kind to me. Len Cobb is a very close friend, and I owe a lot to Len. Now, special thanks to Kelly Branch and Finley Stewart. I am incompetent when it comes to PowerPoint. Without their help, the presentation would not have been possible. This is what we used. This is old slides. That's when we gave talks on cellophane, or we had these slides. And thanks to my wife, who stuck with me for over 62 years through good times and bad times, although I must say I haven't had too many bad times. Thank you very much.